like to talk to you about appendicitis. Now, this is one of the more common imaging indications out of the emergency room and one of the more common presentations of an acute abdomen. Classically, patients present with periumbilical pain that eventually localizes to McBurney's point. McBurney's point lies on a line connecting the umbilicus and the right iliac crest. Patients often have associated nausea, vomiting, fever. On laboratory examination, they will have leukocytosis. However, the clinical diagnosis can be challenging as there are many cases of atypical presentations. The pain can be located in the flank if the patient has a retrocecal appendix. If the patient has a congenital bowel malrotation, pain can actually be on the left side and not the right. If the patient has an inguinal hernia, the appendix can lie in the inguinal hernia and cause inguinal pain. The appendix is a small vestigial structure that arises from the tip of the cecum. It is usually about 2 to 3 centimeters from the ileocecal valve. Appendix has a variable length, being anywhere from 2 to 20 centimeters, and also a variable location within the abdominal cavity. So just kind of talk to you briefly about the various appendiceal. This diagram illustrates the variable positions of the appendix. For reference, this is the ileum, cecum, and this gray structure is the appendix. The appendix can lie lateral to the cecum. In a paracecal location, it can lie posterior to the cecum. In a retrocecal location, it can be directed medially and lie either in front of or behind the ileum. It can extend medially and lie over the sacral promontory and iliopsoas muscle, or it can extend inferiorly from the cecum into the pelvis or in a subcecal location. Due to the variable length and location of the appendix, it can often be challenging to locate a normal appendix on imaging. So what imaging modalities do we utilize to evaluate the appendix? Most commonly out of the emergency room, appendix is imaged with computed tomography with intravenous contrast and depending on the institution, possible oral contrast administration. In pediatric patients and pregnant patients, due to concerns of radiation, ultrasound is often the initial imaging test. In pregnant patients and pediatric patients as well, MRI can be used as a problem-solving tool if the ultrasound is indeterminate. As I mentioned before, finding a normal appendix due to its variable appearance and location can be challenging on cross-sectional imaging. CT scan performs the best in this setting, with, in some studies, up to 85% of normal appendixes being evaluated on CT. As you can see from the slide on ultrasound and MRI, there is less constant visualization of the appendix. With ultrasound, the examination is performed with graded compression. A ultrasound probe is placed in the region of patient's pain, usually in the right lower quadrant, and gentle but firm compression applied. This displaces other loops of bowel from the field of view, allowing us to better evaluate the appendix. When a candidate for an appendix is seen on ultrasound, care is made to trace it back to the right colon. period, once the appendix is confidently diagnosed, is measured. Under ultrasound, a normal appendix is less than 6 millimeters in size. If the appendix is greater than 6 millimeters in size and non-compressible with compression, findings are concerning for appendicitis. Secondary findings would include fluid about the appendix and increased blood flow on color Doppler techniques. This is a transverse image from the appendix. As you can see laterally, this is a normal appearing appendix. This appendix is directed medially. This is the iliac artery and vein, iliopsoas muscle, and then you can see at the end of the appendix it becomes focally dilated, measuring over a centimeter, and this is what is termed a tip appendicitis. Yet another example, calipers measuring the appendix. This appendix is over 8 millimeters and enlarged distally. There is also some hypoechoic fluid about the tip of the appendix, consistent with inflammation. Color Doppler examination was performed, and you can see there is significant vascularity about the appendix. Again, findings compatible with appendicitis. The imaging findings on computed tomography mirror those of ultrasound. Again, a normal diameter is 6 millimeters or less. When the appendix is greater than 10 millimeters, it is almost always abnormal. With computed tomography, we're unable to provide compression on the abdomen, and so there is a more variable size of normal appendix. So on computed tomography, we rely on secondary findings in addition to the size criteria. We will see fat stranding, which represents inflammatory changes within the abdominal fat surrounding the appendix. You can see increased fluid within the lumen appendix. You can see a thickened wall, and an absence of normal air within the appendix is a finding of acute appendicitis. We'll often see appendicolus on CT, though these can be an incidental finding in a normal appendix. On CT scan, we can also assess for perforation. Appendiceal perforation is often a late presentation following the initial pain. Patients have a short window of clinical improvement and then become subsequently more ill. On CT scan, we will see signs of free intraperitoneal or extraluminal air. We'll see free fluid in the pelvis, and the exceptionally delayed cases, actually an appendiceal abscess can form. This is a coronal CT scan of a patient with appendicitis. This is the right side of the abdomen. This is a fluid-filled cecum. These dense structures are appendicolus within the appendix. The appendix is dilated, measures over 10 millimeters, and there are some adjacent inflammatory changes about the appendix. This is an axial image from that same patient. Cross-sectional view of the appendix. The wall is enhancing and thickened. The lumen is distended with fluid. There's some periappendiceal inflammatory change. This is a case of appendiceal perforation. We have several images. There are inflammatory changes in the right lower quadrant. Do not see a normal appendix, but we do see a calcified stone compatible with an appendicolith and a rim-enhancing fluid collection containing air consistent with an appendiceal abscess. So this is a perforated appendix. Once we have diagnosed appendicitis with our imaging techniques, the treatment is almost universally appendectomy, period. There is some experience in Europe with antibiotics for treatment of mild appendicitis. In cases of perforation, Often immediate surgery is not performed, and instead percutaneous drainage of any abscess and fluid collection, as well as intravenous antibiotics, may be given in preparation for a delayed appearance once the initial infection has improved.